I'll go ahead and start. All right. Thank you, everybody, for joining us today. Welcome to our South Texas Regional Family Medicine Grand Rounds. Our educational partner today is the South Central Area Health Education Center, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. All right, thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaged in the session, keeping your cameras on when appropriate. Thank you for registering for CME credit for each session and for completing and submitting a session evaluation form. Today is February 7th. Our activity code today is 1009-3235. You can claim CME credit via text by texting your email address to the number on the screen, 844-502-1338, and then texting attend 1009-3235. You must register for each session by midnight to receive CME credit. This is just a slide on the new CME system, CME credit via text. Again, the code for today, February 7th, 2024, is 1009-3235. You can use the steps on the screen to access your CME transcripts from the Long School of Medicine CME office at cme.utesca.edu. American Academy of Family Physician members can claim credit for this activity using your AAFP login at the website on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to one prescribed credit by the AAFP, and physicians should claim only the credit commensurate with the extent of their participation in the activity. Our Family and Community Medicine Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. Our speaker today, Dr. Lisa Armitige, MD, PhD, has no financial relationships with ineligible companies to disclose. And now Dr. Montanez will introduce our speaker.
Good afternoon, everybody. We want to welcome Dr. Armitige to our Grand Rounds presentation. She is a professor of infectious diseases, internal medicine, and pediatrics at the University of Texas Health Science Center at Tyler. She serves on the staff of Heartland National TB Center as the co-medical director, and is currently the medical director of the San Antonio, Texas Tuberculosis Clinic. In these capacities, she lectures nationally and internationally on tuberculosis and cares for both adult and pediatric patients with TB at the large metropolitan clinic. Dr. Armitige was previously at the McGovern Medical School in Houston, where she did her residency in Med-Peds, has a fellowship in adult infectious diseases, and served as a faculty, caring for both TB and HIV-infected patients. In addition to participating in clinical studies involving treatment-shortening regimens for latent TB, Dr. Armitige conducts biomedical research in the pathogenesis of tuberculosis. We are honored to have her here today. Please give her a warm welcome.
First, I want to say thanks for having me. And I'm hoping y'all are having some lunch because everything's more interesting when your belly's full, I figured out. So let's move along. So I want to talk about just tuberculosis is in 2024. So kind of where are we now with things? There's a lot of changes. A lot of things happened over the last, I don't know if y'all missed it, but there's some stuff that happened over the last like 4 years. So first, I want to just, start by talking about the current epidemiology of TB in the US and globally. I want to talk about the people who are most likely to be exposed to TB or infected. Talk about the diagnostic tools we have. Probably going to give a little rant about the diagnostic tools we don't have, but we'll get to that. And then how to identify and implement treatment regimens to treat patients with tuberculosis, whether that be latent TB infection or whether that be active TB disease. So here's where we are. We were tooling along. On the average, there are about 10 million cases of TB a year. So the estimates, that's the estimate. So these are the number of cases that were actually reported. And you see somewhere about like 2017, to 2018, got kind of serious about saying, well, we're missing some cases. So really starting about like 2013, the WHO really went in and saying there are cases that are just everywhere and we're not getting them diagnosed. So we need to be a little bit more serious about it. So you see the numbers start to increase in 2013 and we're bumping along, and we got 7.1 million out of the 10 million we're expected are out there. And all of a sudden we had COVID, and COVID cured TB. So that's what we learned, right? So COVID did a lot of great things, right? Not so. What happened when you saw the drop? This is incredible. They just the whole focus of the planet went off of the number one infectious diseases killer, TB, and went straight over to COVID. And I will tell you, here in San Antonio at the TB clinic here, my day was spent less about probably equally spent between managing my patients and making sure they were okay, to what am I going to do with my staff. So every day, our staff at the clinic would go out and give patients their medications. We send somebody out daily. They do directly observed therapy. And what this does is that puts eyes on the patient every day. If they have a problem, I know about it that day. If they're vomiting, if they're nauseous, if they have headaches, if they have, itching, rash, whatever, it's a lot of pills and it's a hard regimen. So we send someone out to watch over them. So now all of a sudden I feel like I'm sending my staff into the teeth of the dragon. I'm sending them out into the fire. So we had to have ways of simple things. The patient initials that they took their meds, we didn't want them to touch the pen. We had to, how you handed them the medications to keep everybody safe, but still watch over them. The countries where we didn't have those kind of checks in place, the patients just were forgotten. They were lockdowns, you couldn't come out. So you had a lot more patients that I would say are, that were just kind of overlooked. I had one family, the gentleman had TB, and I think the stress of not being able to find a job and the job that he had, putting him at risk, just kind of amplified what was happening in his body. So he ended up with TB, and then he infected his pregnant wife and his toddler, and also his 6-year-old daughter. So we're in circumstances where the patients normally would not have been around each other as much, or would have been diagnosed a little sooner. But I remember this patient specifically because he kept calling the clinic and he said, I hear the people next door coughing. I know somebody here has COVID. It's going to get me. Can't just get me out. He wanted out of the hospital because that's where all the sick people went. So we recognized after 2020 that between 2019 and 2020 that there was a problem, and we got back in business. So you see globally the numbers increased and improved. And the global report that came out at the end of last year basically said that there's a major global recovery in the number of people being newly diagnosed with TB in 2020. So after 2 years of COVID related disruptions, we seem to be getting back on course. And this had started to moderate the damaging impact of the pandemic, because what we noticed was the number of cases reported went down, but the number of deaths went up. So we took our eyes off of things, and the number of people dying of TB started to increase. So, but, in 2022, TB still remains the second leading cause of death from an infectious agent behind COVID. So if you look at the actual numbers, we were not far behind. So estimated number is always about 1 million people die of TB a year. And it's if you have 1 million people that die of, some uncurable cancer, if you have, 1 million people die of some, but the hardest pill for us to swallow is TB is perfectly curable. It is curable, it is treatable, it is curable, and yet 1 million people worldwide are still dying from it every year. So the estimated numbers of people who are HIV negative, the number of the TB deaths in patients who are co-infected with TB and HIV, those are put into the HIV numbers. So actually, this number is a little higher. But the officially reported number of deaths from COVID worldwide was about 1.24 million. And with TB, we were right behind them at 1.113. And that was not including the patients that were co-infected with TB and HIV. So now you ask why, what happened? We had that same drop. You look at between 2019 and 2020, you have that little cliff drop there. And I remember sitting in the meeting with the director for TB at the CDC, and he's like, we blamed it on everything. Well, we closed the borders. We we have fewer people coming in. We have, I don't know, maybe, well, he didn't say that, but like maybe COVID cured TB, but who knows? Like we didn't had any clue what was happening. But basically all of the resources in public health clinics got switched over. They snatched up my head nurse, and I'm still bitter about this to this day, but she got pulled over into COVID and it just broke her, and she decided that she needed to do something different. And so it was just the overwhelming not knowing, and she was very good at her job and she knew what she was doing. And now all of a sudden they're pulling her into an environment where she wasn't comfortable. So again, COVID broke one of our nurses, but public health just really took a lick. And the public trust in public health and in physicians in general, just a whole lot of things happen. But you see that the numbers are starting to recover, but we still haven't gotten back to where we were. And sure enough, in 2020, there was a 20% drop. It used to be 19, they found some more cases. So 20.3% drop in the number of cases reported. But then the next year you see it went back up, but it still kind of started to level off. But if you look at the same time period, the number of deaths increased. So we got set behind. And the other thing is that, whether you, and I will tell you, you just have to trust me on this, but the data from the CDC showed when you looked at across all racial lines, African American, Caucasian, American Indian, Latino, Hispanic, every ethnic group had the same 20% drop. Every age group had the same 20% drop. Like no one was disproportionately affected. Everyone was affected in a negative way. So all of the numbers dropped. But when you look at TB in the US, why don't you look back and I'm dating, like I'm giving away my age, but in 1993, I was a little bit, a few years ahead of that when I was in med school. I remember an ID doc guy named Terry Satterwhite, still keep up with him, still one of my mentors. But he said, if you're looking for someone who is born outside the US to be the model of the patient you see with TB, then you're looking in the wrong place. And surely in the early 90s, it was primarily US born individuals that had TB. But if you look at the blue bars at the top, that is the percent of people who basically are born outside of the US and have TB. And if you follow that bar all the way down to currently where we are, it has not changed. So I feel like that is a fail. We are failing the individuals who come here and melt into our pot. If you're, born outside the US, your rates are still the same. So basically now we're about 74%. When I was in medical school, it was about the opposite. About 75% of persons who had TB were US born and 25% were non-US born. Now we've just kind of flipped that. So we've made some great gains, but we have not gained, everybody's gain is not equal. These just represents the countries where you see the highest incidence of the countries that individuals born outside the US hail from. But I think this is one of the most important ones, and I want to start engaging some allies here. So if you look at the number of years the individuals who were born outside the US have been in the US, over half have been here more than 10 years. So these are individuals who have melted into our pot. If you get down to that bump at greater than 40 years, they have come here. They have had children. They've had grandchildren. They have worked, paid taxes. They have retired. They are now living their best life and spoiling some grandkids somewhere, hopefully. And, and these are the individuals that we're seeing, like over half of the time. So screening where are the lost folks? And I gave the example is when a lot of folks immigrated to the US, especially in the 80s and 90s, then they come in and you tell them, okay, you do a skin test, and they've been told in their country of origin, you had BCG. So therefore your skin test just is a cross reaction and you don't have TB. You just have a positive skin test because you had BCG. I'm going to ask one question. Does anybody know, in all comers, if I measure in everyone who has had BCG and I do a skin test now, what percent of those people will have a positive, that people who had BCG, what percent of those will have a positive skin test? Throw out an answer. 25% is a good answer. 50, 75. Yeah. So it's actually 17%. So it's so everybody thinks that, yeah, once you have BCG, your skin test will be positive for life. They actually were doing a study where they were looking at the IGRAs and looking at how, at what, so they did testing. They did tuberculin skin test, they did a quantiferon, and they did a T-spot because they were trying to kind of characterize how you best measure individuals who are coming in. And these were all individuals coming into the country. So about 17%. So I'm always like, I get that patient who's like 56 years old and they're like, no, I have the skin test because I have. I'm like, dude, you got that vaccine when you were born. And so 56 years later, I don't think your immune system still remembers that one vaccine. So maybe not, so, and obviously in younger children who have more recently BCG vaccinated, it'll be a little bit higher, but just keeping that in mind. So these, folks came here and they were told, you have a positive skin test, or you have to take some medicine. They're young, healthy. They don't feel sick. They don't understand why they're taking it. And when you don't speak a person's language, if you just say it louder and more slowly, suddenly now they understand everything, right? So, it was never explained to the individuals who came, what the point was and what it meant. And in 9 months of taking something that when you're not sick is a long time. So I think a lot of things got missed, and we're starting to see those individuals show up now, but now they have active disease. Globally, just touching on children, soft spot in my heart. I'm a pediatrician in addition to being an internist. We're looking at about, 1 million children every year that develop TB. This is 2017 is the last time. And this is always kind of sticks in my craw because we only get the pediatric numbers, every once in a blue moon. Like nobody loves on the babies except me, but that's okay. And I'm sure plenty of y'all out there, y'all nodding the head, you understand, that you never get the pediatric numbers. But, we're looking at, over 200,000 deaths from TB worldwide, and it's 80% of it is in children under 5. So the most vulnerable are the hardest to diagnose. Here in the US, I told you the 18% drop, it's from 2019 to 2020, there was an 18% drop in pediatric TB case detection. So we're right at about 4.4% of children are represented as our number of cases. And overall, the biggest number in 1 to 4 year olds. Not sure what that is, but I remember a lady that had her knee nearly destroyed by TB, and she had 2 babies, a 6-month-old and a 2-year-old. And they were both US born, so we just did skin tests because they were small. But every day she couldn't run around and chase the 2-year-old, so she just her husband left, food for them for the day, and she just shut the door, and the 2-year-old ran all over the place, and the 6-month-old stayed in the bed with her. The 6-month-old tested negative. We tested that baby I don't know, I think I don't know how many TSTs we put on that baby. We just could not believe that she didn't get that baby, but we're figuring that, the larger droplets are missing the baby, but I bet she's yelling at that 2-year-old all day long, right? So, just different ways that you see things, but most important thing I want you to take away, this is your risk of active TB if you're infected and by your age and infection. So if you're infected between birth and 1 year of age, and that bug gets in your body, you have a 43% chance that you will progress to active disease. So keep in mind, your healthy adults down here, 5 to 10%. So if I had like 100 people get infected with TB, then about 5 to 10 of them, and closer to 10 of them will progress to active disease. And then, you have another, the numbers kind of go into other places after that. But if you're a baby, you're almost, 50-50 chance. So when we're very aggressive with, screening in the little ones, 1 to 5, your risk of progressing to active disease goes down to about 25%. But then 6 to 10, when children are really sweet, and I don't know, even the TB's nice to them, I guess. I don't know. Then they get to be honorary tweens and teenagers, and you see the numbers go back up. We're not sure what that is. It may be some hormonal thing, but if your risk between birth and 12 months of age, disease 50%, pulmonary disease about 30 to 40%, but miliary or TB meningitis 10 to 20%. So this is why if you've ever had a baby that, was exposed to someone and had a positive TST and you call us at the clinic, we're going to tell you need to do a lumbar puncture. I don't care if that baby looks beautiful, you need to do a lumbar puncture. So this is why the chances are 10 to 20% that child would have, TB meningitis without you even being able to detect it. And that drops off considerably by the time the child hits 1 to 2 years old. So let's talk about TB screening. So the first question is, who should we be testing for TB now? When I was a pediatric intern, every child came in for their 1-year checkup, and we checked lead levels, we checked a hemoglobin, and we did a TST. That was in Houston. And I had a lot of negative TSTs and very angry babies, but that was what we did. And then we figured out that for pediatrics, just asking a series of 4 questions, have you been out, outside the country? Has someone from outside the country visited in your home? And have you been around someone who was recently incarcerated? So it's like it gets down to a very short number of questions for pediatrics. And we figured that out for kids. It's more the adults around them and where they've been taken to. But the simplified version is basically persons who are at risk for TB infection. These are the highest risk. And where would you guess you're at highest risk for being exposed to tuberculosis? And it's simple. Being in the household with someone who has active TB. That is our bread and butter. Our contact investigations always start with the household contacts. So we start there and then we go outward. And so if you have not, you have to have the bug. So I know you've been told by your mom, if you go out that door without the proper outerwear, if you do not have a sweater on under your coat, it's 30 degrees outside, you're going to get a cold. My mom used to tell me you get pneumonia in the ass. And I'm like, I didn't even know you could do that, but that was her thing. But that was her point she would make. My mom's a nurse, by the way. I feel like I survived something, but I just put that out there. But if you have to have the germ though, so you can go out and you can be cold and you can let your immunity drop, but you still have to have a cold to cooperate. Same thing with TB. So you can be in high risk countries, but you still have to be somewhere where somebody is exhaling the bug to be able to get. But the second group, we screen persons at increase for progression to active disease if infected. So we screen every child. So any child that is somewhere near the airspace of a person with active disease, we know that the disease is very bad with those individuals. So little ones, we screen everybody. But really, we start asking some questions. Were you in the airspace with someone who had disease? So that's the first group. And the second group is the people at high risk. When you get down to other reasons for testing, administrative reasons, mandatory employment testing is generally included. And then persons who have symptoms of active disease, then who have either fever, night sweats, cough, weight loss, and those are suggestive of disease, those people should be screened. So really it gets down to just this group here instead of screening everybody. Then the one question is, were you somewhere where TB is more prevalent and you could have inhaled it? If the answer is yes, then they should be screened. And the USPSTF actually agrees. So their recommendations for TB screening are basically for people at high risk, and this is a B rating. They started off with for individuals who are born outside the US or who travel frequently outside the US, and also individuals who are in congregate settings. So what does that mean for you? So we're healthcare workers, and okay, I will tell you, I had a positive skin test as a second year med student. So I got a chest x-ray and I got 6 months of isoniazid. And then I went to residency and I got another chest x-ray because I was already positive. So they couldn't put another skin test on me. So I got another chest x-ray. Then I went on to faculty and I got another chest x-ray and I lasted about 5 minutes and I went back into fellowship. And after that, and I'm just like, enough. So I think I did the one for fellowship, but after that, I'm just like asking some questions. I'm like, dude, like really? So I think I'd had about enough at that point. So healthcare worker screening. Important, for you to know, the recommendation used to be it was kind of complicated. If you were in a high burden setting, and yeah, you should have and so there was a lot of screening that was done. So if you're at a hospital that has X number of cases per year, you should be screened annually, and then or you should not be screening. And so people got confused. So then they just kind of broke it down. After all of that screening, here's another one. What percent of healthcare workers do you think, actually develop active TB disease in a year? Now, one is just nailing it back there. But yeah, it's about 2.4%. Like just where you are, 2 to 4%. That's a lot of screening that's not a lot of juice on that squeeze, right? So they started looking at, doing testing at employment. So let's see where you're starting off, because maybe you've already inhaled that bug somewhere. So let's start off with where you are, test it when you come in, and then, I would say like some areas like, I would say the ER. The ER is always hard to kind of wrangle. You have a lot of individuals coming at you very quick and they're very sick. But in general, going backward from when a person is diagnosed with active tuberculosis, if they're coming to our clinic and you send us somebody and you did not know, we always tell you. We always go back to infection control and we let them know that this person tested positive so that anyone who is in that airspace can be tested. But that was a much more fruitful approach than just screening healthcare workers every year. And there was an individual risk assessment. So if you did you did an away elective and spent a month in Ghana, which has really high rates, maybe you'd be a little bit more at risk than your person who, spend theirs in the allergy clinic, for example. Okay, a little bit different risk there. So maybe we just test you when you come back into the country. But the biggest thing is those who test positive. And it's like, if you're gonna test somebody, shouldn't we be doing something, right? We did a study with kind of doing high risk testing, and we employed a physician down in the valley, and he was doing the healthcare worker screening. So when the people there screened positive, he was not comfortable with treating for LTBI. So he basically told them, you're young and healthy. You only got a 10% chance you'll break down with disease. I wouldn't worry about it. Needless to say, that little mushroom cloud emoji, that was me right after the cuss mouth emoji. So I'm like, just because you're not comfortable doing something should not be something that you should discourage somebody from. So I'm gonna get y'all comfortable and tell you how to get even more comfortable, but we're gonna start treating folks. So if those of you out there who have tested positive and been given some misinformation, and all you hear is 9 months of INH and you can't drink, I got something for you. We're gonna get you treated, get you taken care of. So TB screening test, the tuberculin skin test is 100 and I think 50 something, 130 something, 1884, Robert Koch. Yes, long, old, still old skin test, injecting what one of our experts likes to call TB poop into your arm and looking for a reaction. The interferon gamma release assays, much better. And I'll tell you a lot of reasons why. We have nucleic acid amplification tests. Our bread and butter is AFB smear and culture. So they should go hand in hand. And then some of the adenosine deaminase assays that are used now for like fluids, for like pleural fluids and peritoneal fluids. But really, culture is the only test that definitively diagnoses TB. After that, it takes some expertise. 20% of cases, 17 to 20% of cases in the US every year are really based on clinical response to treatment and the bugs are hard to get. So this is the old, 1.1 mLs tuberculin, 5 tuberculin units is contained in that 0.1 mLs of purified protein derivative, and you inject it intradermally, not intramuscularly or intravenously, or hopefully intradermally. Hopefully somebody's done it and showed you how to do it. We had a mass exodus of nurses in the state of Texas, and like it used to be like that see one, do one, teach one, like, or see about 50, because all healthcare, the public health nurses didn't play, and then you had to do another 50 with their like eyes on that, and then then you were able to teach other people. But they just fled. And so we actually had training courses at Heartland on how to properly place a skin test. So I have to ask in this room, how many people have placed the tuberculin skin test? Oh, dang. We all got, well, we got one with no gray hair. Okay. One. That's it. Okay. The one, no hair, no hair or gray, no hair or gray hair. Yeah. So this is a long time. This was our as a third year medical student, that was my job. You know, you get a handful of needles in your pocket and the tuberculin solution. And then we had PPD rounds, like after post call, that's what we did. We went and put TSTs on all of our patients and marked them up with a nice little circle so you know where you put it and all of that. But this is getting to be a dying art. Really, the hard part as a patient is the proper placement and reading, and the patients actually have to come back 48 to 72 hours later. This is the QuantiFERON Gold Plus. The three tubes that are not highlighted were the old QuantiFERON Gold. The Plus just adds an additional tube that's supposed to increase sensitivity. This has been the work of many papers, and it really pretty much behaves about the same. So it didn't do any better or worse, but that's the test we have now. And then the T-spot is literally, they count spots, the number of footprints that cells that secrete interferon gamma leave on the membrane when they process it. So the interferon gamma release assays, they are replacing the TST in many jurisdictions. And the biggest draw is it's a blood test. That could be a good thing or a bad thing. If you're going to have a needle, you might as well, you know, like you at least get an answer out of it. The nice thing about the interferon gamma assays is they have a positive and a negative control. And invariably, you're gonna, you know, there's 4 tubes. That was it's a negative. Now, can you imagine you had a hostile 2-year-old and you have just pulled out a needle? So now we have declared war upon one another. Like, the 2-year-old is not having it. You are now my sworn enemy. And if I could gouge your eyes out or headbutt you, I would do it. It's the 2-year-old's approach to things. And now you have to pin that kid down, get a needle in their arm, and heal in 4 different tubes. So they actually, you could, you know, there are ways to do it. You can do one, something short of pinching that child's nostrils until they pass out. Like, you can't do that. That's illegal. And so, you know, we have to do something. But there are ways, you know, now you can just draw into a single tube and send it to the lab. But they, you know, they know how to, the phlebotomists know how to make that work. But, you know, in either regard, having something that is not as prone to, let's see, it's not as subjective. It's very objective number, right? Because I can tell you what happens in the health department. You raise a wheel and they come back and there's a bump there. Okay. Now you have to measure. If it's 5 millimeters, then that's positive in people who are, you know, at very high risk. If it is 10 millimeters, as people at moderate risk, healthcare workers, you know, people who work in the lab, people who have been, you know, like work in jails, et cetera. And then 15 millimeters is positive in everybody. Okay. So now you got to know something about the patient. You got to know, you know, and also you got to rub that arm and you got to hope that it has very hard edges. So you take your really expensive, you know, tool that you read that with, which old school ballpoint pens. We still have that at Heartland because they don't like the gel pens don't roll as well. So you run up to the induration and you stop, and then you run up to the induration from the other side and stop, and then you measure between the two. Really very precision, right? And let me tell you, the more hard-headed that patient is, you're like, that's a 9, that negative. Yeah. But the other thing is the patient coming back for treatment, like, are coming back to read it, they're off on Monday. You place that skin test on Monday. It has to be read between 48 to 72 hours. You make it very clear. And they'll come back when they're off the next Monday. And there's a hint of a bump there. And they tell you, oh yeah, it was big and red last week. You know, so now we're getting, it's more specific in that it is not prone to to being affected by BCG. So this is the biggest get. So in your patients who have had BCG, this is not impacted by that. It is equally sensitive to the TST. TST in some circumstances might be a little bit more sensitive, but pretty much, you know, what you need to get done doesn't require the patient to return for a reading. And then, like I said, you eliminate the false positive TST due to BCG. So this is kind of where we're going. But what does it tell you? So an IGRA, will tell you if your immune system has seen TB. So let me say, if I come to your house and I say, is there a serial killer in your house? And you say, I saw him. Okay, but is he in there now? That I don't know. But I can tell you that I saw him. Well, okay. So this is what, I mean, the IGRAs will tell you if TB got into that person, if it got in there. And if I have that as a constellation of things with a person who has now got cavitary lesions in their chest and they're having night sweats and weight loss. Yeah, okay, all that kind of goes, that fits, but it's just one tool. So just understand, all that test tells you is, was that bug ever in that person's body, and does their immune system register that it was in there? And the answer is yes. If it's still in there, I don't know, but it was in there at least one time. So if they, are well now, I'm just going to assume it's still in there. I'm going to try to go kill it, because that's what I do. That's my job. Okay. For the AAP Red Book, in 2021, it's about to come out, and I had that in red. So basically immunocompetent children greater than 2 years of age, and all the circumstances you would to use a TST, you can also use an IGRA. Okay. IGRAs are preferred for children who are BCG vaccinated for obvious reasons. Data shows that IGRAs perform consistently well in 2 years and older, and some experts use down to 1. I would be one of them. So, I know refugee clinic, we'd had some conversations here. There was some comfort level, and I told them, just draw it and send them to me, and I'll make if you're not comfortable with putting all of the parts together about risk, send them to me. But I feel confident that the test is going to perform pretty much the same. And the new Red Book's going to say, in every circumstance to use a TST, you can use an IGRA. Please understand, this is all tests are unreliable in children under 6 months of age. Under 6 months of age, your immune system is still trying to get there. If I'm asking you to read something, I have a better chance at 5, you can identify the letter A than at 2. And at 6 months, like the younger you get, the less your immune system is good at figuring stuff out. So treatments. Now treatment options. CDC and the National TB Consortium of America preferentially recommends short course rifamycin-based 3 or 4 month latent TB treatments. Notice all the way down at the bottom, INH. So in the old days, you test positive for TB, you have an internal meltdown. I guess you go try to drink everything you can, because they're going to put you on some medicines you can't drink. If you're binge drinking, call me. You shouldn't be doing that anyway. But, let's just say, okay, I'm going to get 9 months. And you think about all the things that happen, 9 months. And I used to tell people 9 months, like 9 months, you start with a single ovum and you get a whole baby, right? Here, you just get 9 months of no St. Patty's Day, no Valentine's Day, whether it be a good day or a bad day, no, Christmas, no my crazy family at Thanksgiving, none of that. Like, so with the newer regimens, my most favorite, INH and rifapentine. So rifapentine is a long-acting rifamycin. So unlike rifampin, it's like rifampin, but it hangs around longer. So rifampin is that magic drug that lets you shorten the regimen, but also increases a cure. So if you have rifampin in your regimen, you are going to cure. It is good at going into tight places and rooting that bug out and evacuating it from your person. So that is the magic drug. So now we got one that acts over a long period of time. So once a week, you take it's about 10 pills. It's a lot. 10 pills once a week and done. 12 times. That's it. Okay. Rifampin, that's our next option. And for people who just can't take that much medicine, rifampin, 2 capsules once a day for 4 months. And then you can do INH and rifampin. This one is used mostly in like the UK has just studies after studies. It made it into ours. We don't hardly ever use it here. Sometimes I pull that tool out when we're treating for LTBI in our clinic, but you can give the standard dose of INH, standard dose of rifampin, and you can treat for 3 months with that. And then way down there at the bottom, unless you just hate your patient, don't do that. Okay. In some cases, patients, if they, some of the HIV meds don't work with any of the rifamycin. So sometimes you have to throw in the INH with that. But really 6 months should be enough to treat just about anybody who is on any treatment medication, treatment for HIV. Okay. So let's stop being mean to and pregnant ladies, that's a whole nother lecture. So here is really where we started. INH hepatotoxicity. So you have asymptomatic elevations of the transaminases in 20% of patients. 1 in 5 patients, if you're just checking, they will have a mild bump in their transaminases that will come back down. Clinical hepatitis, 0.6%. But people would see that number and they're just like, I don't want to be following them. I don't want to. Fulminant hepatitis, 4 out of 100,000 cases. In every case, the patient was educated to, if you have, any problems feeling with nausea or flu-like symptoms or, any other, symptoms that, are right upper quadrant pain, yellowing the eyes, any of that, call the clinic and stop the treatment. Well, in all of the cases of fulminant hepatitis, the patient continued to take the treatment, did not stop. So all of them, none of them necessarily needed to have a problem, but it's just the education and not, the regimen itself that is so harsh that it can't be given safely. So duration of treatment, I'm just putting up 12 doses. If you do 3 HP, only 120 doses and 270 doses. 270 times you're doing something. That's not fun, okay? I wouldn't even want to eat Cheetos 270 days out of the year. And that's one of my favorites, right? So moving forward to where we are now. So this was, I stole, that sounds so criminal. I acquired this from the treatment action group. It's a great group. TAG is looking at, at how we're progressing and moving things forward. But treatment shortening, really, I just want to point out that, these are the two I'm going to discuss here. But as in the 1980s was when we got, like, the end of the 70s, 80s was when we got short 4 months, the 4-drug treatment with RIPE, INH, rifampin, PZA, and ethambutol. That was the 80s. I had big hair by then. But I'm just shocked at how recent that was. When I got into the field, that was only about now 40 years ago. And I only, okay, I got you. Got it. But still, relatively speaking, in the time that we have had HIV go from, just when I was a student, when we had 3 drugs, AZT, DDI, and DDC, 2 of which were so toxic that now they're not even in use anymore. From then to now, we have had 3 new TB drugs, and HIV has like this whole beautiful cornucopia. There's color coded, and you have one pill that has 5 things in it, and you only take it once a day, and we're still shoveling a lot of pills in our patients. So we want treatment shortening, and we want, I can't treat, I can barely get 10 days of treatment into me for a, cellulitis. And now I got to take, 6 months, 8 months, 9 months. Okay. So now we have a shorter treatment regimen in children. And I'll just whip through this one real quickly. The trial design is basically, if the child was going to be started on TB treatment, then they qualified, but they couldn't have really severe disease. So we have a lot of kids that we go into the house and we figure out that they've been around, the person who has active disease, and we're screening that child, and they have lymph nodes in their chest, or they have, a lymph node in their neck, or they have a little infiltrate in their lungs, and we're treating them 6 months. You just a hard line in the sand, 6 months. I'm dosing this little person for their weight. So, I mean, just think, I would say that think of the tiniest person you can think of, adult. That person would get, if they weigh at least 100 pounds, they would get, 600 milligrams of rifampin, but so was Shaquille O'Neal, right? Who might be 3 of them. So Dr. Seaworth is really tiny. She weighed 100 pounds. And in my head, I thought soaking wet, but yeah, but she's just tiny. And every time I look at her and I think her and Shaquille O'Neal, who's about 3.3 Barbara Seaworths, would actually get the same dose of rifampin. Unlike that in children, I dose them for their size. If they're tiny, they get a smaller dose, but if they're bigger, they get a bigger dose. So I'm chasing them down size-wise, and I'm still treating them for the maximum length of treatment, right? So we wondered, 4 months of treatment works in adults with minimal disease. Would that work in children? So some inclusion criterion, 0 to 6 years old. 16 years of age, the clinician had to decided that they were going to start treatment, because frequently you don't get positive cultures on them. And then they could be symptomatic, but they had to have non-severe disease. And what that meant was Basically, if they were smear positive, that was more severe than was manageable. Miliary, spinal, TB meningitis, like anywhere, and in serious, hard to get spaces where you don't want to shorten treatment. If they were severely ill, pregnant, every time I put pregnant on something with a kid, with the children's, it kind of crushes my soul a little bit. But anyway, that was one of the criterion. And so they were randomized to either 4 months of treatment or 6 months of treatment. Everybody got the first 2 months were all 4 drugs. The next 2 months were just 2 drugs. And so really, to whip through real quick, looked real good. So forest plot, on the line of 0 and left leaning being, 4-month treatment better, 6 month almost right on that line. So now we're starting to, when I treat kids, I'm quantifying how much disease they had and going to the shorter regimens, but 97% in both groups had great outcomes. So what about some adults? We're tired of 4 months of, I want some 4 months something for my adults. Okay, a little bit more complicated with them. 2,200 patients that we looked at, 1,700 had a cavity. Don't give me just something and say, well, I got a little puff of disease and everything will cure that. Give me some people with some real disease. This was a non-inferiority study. The first arm, rifapentine, they replaced rifampin with a longer acting rifamycin, rifapentine. The second one, they replaced ethambutol, which is a considerably weaker drug, with moxifloxacin. And to cut to the chase, the one with just rifapentine is at the bottom. It did crossed over the line at 0, and it was considered, not a better option. There was some statistics, and I actually sat in the room with the guy, and he's like, so it's some really complicated stuff. And I'm like, he got ready to pull out some formula. I'm like, stop. 6.6. It's like it could only be 6.6 worse. And you see that when you add moxifloxacin and long-acting rifapentine, it worked well. So why aren't we using this? Pill burden. So I go from my normal, with my patients who are on RIPE, they go from 3 to 12 pills up to 11 to 15 pills every single day. So it's a lot of pills. So we're looking at safe and it works, but how well is it tolerated? We're still working that out. Getting people familiar with the regimen, and then drug shortages. Rifapentine is kind of perpetually in shortage. I'll talk a little bit about drug-resistant TB because this is where the biggest gains are, but I'm going to go relatively quickly and leave some time for questions. So the standard of care for TB treatment pre-2019, 20 to 24 months of treatment, 6 to 8 months of an injectable every single day, 4 to 6 less effective second-line drugs, and 50% of people cured and 10% died. The 50% the 40% that didn't die or cure, those remained smear positive and infected other individuals. So this guidance came out, and I mentioned Barbara Seaworth before. She's our other co-medical director. She works with us at Heartland as one of the national experts on drug-resistant TB, was on with this, and where they actually looked at every individual drug in the regimen and figured out which ones worked most effectively. And also this study came along. This, I tell you, changed lives. So they looked at 3 drugs: bedaquiline, a brand new drug nobody had heard of, protontinib, and linezolid. And they came at the patients with these 3 drugs. Bedaquiline is good in starting to kind of get used a little bit more in patients with non-tuberculous mycobacteria and persistent regimens and the persistent infections and stuff. Open label, only 109 patients. This was their last, gasp, basically. And when they looked at basically time to curing, to basically clearing their sputums from them being smear positive, this was like something never heard of. Many patients were curing, and they cured in 6 months. And this was something I'd never seen before. Adverse events, 100%. 100% of every person in every arm had a toxicity. And I'm like, is that ethical? Like, is that legal? Like, I never seen this before, right? And it wasn't just, that it was just some random thing. Over half of them had like grade 3 or grade 4, which is the highest grade. And really, it was the linezolid. A lot of people were getting horrible toxicity in their fingertips and in their feet burning out all of their nerves, but they didn't die of TB. So they looked to see if they could kind of dial that down a little bit. And I thought, yeah, let's down a little bit, right? And see if we can do something different with the linezolid dose. So we went from 1200 daily to 1200 just for the first 2 months to just 600 daily to just 600 for the first 2 months. And all of them look good except the 600 every 2 months. So for the first 2 months, you needed 600 at least for the majority of the regimen. But if you look, let's go back one, actually, we went from 50%, 60%, high grade adverse events down to about 20-25%. So significant improvement. And now the regimen has gone from 20 to 24 months of treatment with with shots. We're like I say, the shots in the backside. We're all friends until you come out with a needle, and every day shots in the backside, and they sting. So we went from that down to just 6 months of an all oral regimen. So that, like I said, was the biggest get for TB in our field. So we're starting to look at these other drugs, and the TB Practical study was just the next one that showed 0 deaths, 89% of people cured who had multi-drug resistant TB, and only 20% had side effects. So quick review. Our TB treatment regimens, we are at for LTBI, which I don't like the word latent because it's not really latent, it's just kind of hidden, but I just say TB infection. So TB infection, we have 3 months of, once weekly dosing. We have 4 months of rifampin. We have 3 months of INH and rifampin together. And then we have that 6 months to 9 months of isoniazid, which I feel like you should have to call me so I can talk you off the ledge and get you better with that. But new coming up, they're looking at in HIV infected patients. They had a study 1 HP. That was 1 month of isoniazid and rifapentine every single day. There were a lot of flaws in that study, and there's a lot of, like, those of us who know the study had some concerns, but obviously the people who did it are like, yeah, it's like the best thing ever. It did work in some populations. I couldn't tell you from the way they ran it, the way it's working. At the City Chest, we're actually in with a study with 6 weeks of rifapentine every day. So we may get that 3 months down to just a month and a half. And eventually we may get down to even smaller than that, but we're looking. The drug susceptible TB, the 2 studies I showed you, basically in children, we've shortened to 4 months, and in adults, we have a whole boatload of pills. And then the drug resistant TB, we're looking at bedaquiline, linezolid, fluoroquinolones, and predominant regimens. Our superstar drug is bedaquiline. This is what has changed. It is the best, the closest to replacing rifampin that we've had in like ever. And so this is the drug that has let us go from 20 to, from almost 2 years of treatment down to just 6 months for patient with multi-drug resistant TB, but we're already starting to see some signs that we need to be concerned. There's just a slide to talk about, the one paper looked at 8,000 people who were enrolled in studies involving bedaquiline. And at baseline, there's already almost 4% resistance in the population of organisms. There's about 3.6% in people who had never taken bedaquiline, but people who had taken it before, or a kind of similar drug that's used for leprosy, clofazimine, 20%, almost, 1 in 5. So we're seeing, just something, on the radar to be thinking about. So I just want to wrap up. So screening for TB should be considered in non-US born individuals who have not been previously screened or who spend significant time in higher risk countries. And I always say, I grew up in, my parents are from a little teeny town near Waco and Huntsville. So if Huntsville was a foreign country, I'd be exposed to everything. Cause like every summer we went there, so it's just, if folks, and I think the one place you feel safe you want to send your kids is where you grew up. So a lot of folks will send their kids down to Mexico, and when we're doing the treatment for TB infection, we just cut them off. When they come back from grandma's a little fatter than when they left, we just pick them up. So we try to make sure that we're in the right range to get them finished on treatment. So we work around that. Healthcare worker screening should be focused less on annual screening of low-risk individuals and more on treatment of workers that test positive. So the take home is everyone who is testing positive and should be tested and are positive should be tested. Should be treated. So treatment regimens for TB are shortening. That's what's happening in 2024. We are finally getting to be less long. Fluoroquinolones are playing a larger role in what we're doing. So if you're giving those out indiscriminately, please, if you see something on your chest x-ray and you have not ruled out TB, please collect a sputum. Think about that, because we do get, most people start escalating. They start right within the community acquired pneumonia recommendations, and they do that, and then they don't respond. So they invariably go to a fluoroquinolone, and that kills my cultures. And I'm not going to lie to you, I think less of you. If the patient comes to me and I'm waiting for that fluoroquinolone to wear off so I can get some good AFB cultures, I do think a little less of you, sorry. But no, not sorry. Okay. So treatment regimens for drug TB, resistant TB, in the US and worldwide have gone from human rights assaults on individuals to actual treatments that are beneficial for the person and don't steal their life. And this was one, the biggest one was the injectables. Injectables, and these are young, healthy people, and they would wake up one day with some fullness in their ear, and then the next day, deaf, never to be returned. So you have young folks going to university, going to med school, law school in their country, and all of a sudden now they're having to adjust to a life with no hearing at all. And so, and I still feel like this is the most heartless thing I've ever heard. And my boss was like, yeah, they used to say, yeah, better deaf than dead. Is it? Like, how do you pick that from somebody? So we are very, with TB, very big on stigma, but very big on patient, engaging the patient in their care and in their treatment, what is best for them. When I have that list of treatments for LTBI, I know my favorite, but if that doesn't work for the patient, then we're going to go with what works for them. So mechanisms of testing and surveillance have not grown. They have not kept pace. Like I can't get bedaquiline MICs or, or linezolid, some tested against TB. I know some things, but a lot of things we're still escalating, but we haven't caught that up. But a little bit about us, the Heartland National TB Center. We are a team of experienced professionals. We're very passionate about what we do. Somewhat irreverent in my speaking sometimes, but anyhow, this is our whole crew of folks. At the top left corner, this is Barbara Seaworth, was the founder of our center. She and I are co-directors. And next around the circle, that's our executive director, Hal, and Alicia's our project coordinator, and Swiss Army knife. Then you come around, that's Salma on the over by the D in Heartland. That's one of our nurses, Chelsea, Debbie, Lauren, Delphina, and Catalina. So Salma, Debbie, and Catalina are nurses, and then the other three, Delphina and Lauren and Chelsea, are our trainers. And I put them out there because we have a lot of trainings that we'll hope y'all will consider joining. So basically, we provide medical consultation. Say you have a complicated patient and you're not quite sure what to do with them, you can call us up free of charge, and the state of Texas pays us basically to answer your questions. So if you just have some questions that you want to ask, you can call up and ask. We provide that service for nurses, for health departments, for private physicians, basically whoever calls, and I'll give you the number. We do develop state-of-the-art trainings. We have some trainings coming up, hopefully to see some of y'all. We have like mini fellowships over with the clinic. We haven't seen as much of those, and I talked to, about maybe having some of y'all come out and rotate. If I am just, like we're busting at the seams, but I have clinic 2 days a week, and pretty much you get more of the same. We get a lot of really, like-minded folks that are trying to get people better and make people well. But we also have innovative, we think, innovative educational and consultative resources. Wanted to show you one. This is we have a kind of a little pocket book on the spectrum of TB that basically covers everything, including, like radiographic findings, TB and HIV, the principles of drug resistance, treatment. It has all of the treatment tables so that you don't have to calculate in your head. But for those of you who are about to graduate and go out, we've actually developed a tool to tell you how to do your billing and coding for LTBI. So each of the tests that you do, then it tells you how to, what they mean in the text. We try to keep more of a get or done kind of thing. I don't feel like you can read a textbook and we just feel like that's not necessary. So we just kind of break it down for the cheap seats. So that's what most of our products do. And also like for children, you know, if you're treating kids and you need to know how to properly dose the meds for LTBI, then we have a lot of them go to the health departments, but how to screen, who to screen, and such as. But that is everything I have today, and I think I left just a little bit of time for questions. Well, we're getting late on things, but
Is so I guess I've only really dealt with, late TB infections or
Mhm.
TB infections.
Mhm.
Is there a significant amount of drug monitoring difference? I honestly don't even know if I'm assuming they're
So-
changing them between the regimens.
right. So they're all the same. So we recommend once a month, you have the patient, just touch base with the patient, make sure they're not having any toxicity and make sure they're taking the meds. So if the patient has I don't know, like my eyelid itched once, so I stopped taking it, and you find that out a month later, right? So if the patient has active TB disease, we can't have that. So we have somebody with DOT, but we're not just documenting that they had a problem. We're fixing the problem and moving forward, keeping them comfortable so they can go back to work, so they can raise their kids, you know. So with treating for LTBI, that tolerance for side effects is very low because they already don't feel poorly. And now you're asking them to take a med. So would recommend check-ins, you know, at least once a month. But and a lot of the patients they've gotten older, they have a lot of comorbid conditions. So we will check baseline, you know, chemistries and then just a chemist, a CDC, a CBC, and a CMP baseline. And then I usually check one at a month. And if they're trending okay, you know, it's a short regimen and we're all done. But you will see, I used to get patients on isoniazid and somewhere around 4 or 5 months, they would either lose focus or those numbers start trending upward. And you still got to get to 9 months, which is all, you know, so really, I will tell you that all of the studies showed that people start losing interest in taking the meds about 4.5, 5 months in. And if you're on a 4-month or 3-month regimen, you're done before they even lose focus. So it's a good question though. But anyhow, so like I said, feel free to reach out and I'm hoping that y'all will go to the website. We have a lot of the products here. They're all free. Products are free. The advice is free. I should have a mentor that said it's worth what you pay for it, but I do actually try to keep up with stuff. So hopefully you know, it's worth a little bit beyond that, but you know, come by and visit us. Sometimes we're on the campus with the TB hospital and the city chest clinic. We're all together. My office is right in the middle of there. So anyway, there's no other questions. I guess we're all done.
Well, we're in the military, but if you're in the military and you're in a unit, they give you a unit coin. So this
You
is
know
just
what?
a
I was
small
not,
thank you from us.
I was not in the military, but I have been given one of these and I do appreciate them. So, and I have them displayed in my office.
There
Thank you
you
so
go.
much.
So thank you very much for the outstanding grammar.
Thank you so much, Dr.